Hello, lower extremity. I'm Maggie Henja. I'm a fellow in training and your guys' TA. I'll be taking over this week's recap as Bill has passed the baton on for the week. I'll venture into kind of some take-home points that we should be taking away from this week and how we apply that into clinic and some practical pearls that we had discussed this week and some great take-home points that you guys brought up in your posts. So. Starting off, we have those three videos we saw, Dr. Minkin, Flynn, and Tahan, all in different areas and all extremely applicable to us. Dr. Minkin spun us off with some excellent discussion in the literature in ankle sprains, which I'll save because there's some great discussion here, but this is in our upcoming week, so make sure you take notes because this can be of help. But he did talk about that plantar heel pain and how frequent we see these patients and what kind of literature there is out there for management of the patient with the foot and ankle pain. Um, and Tim Flynn kind of carried that on within. Okay, so we know that we see this patient often in clinic when that stress-related injury or that ankle pathology and even that Achilles tendinopathy, that's extremely frequently visited uh, pathology we're treating. So different things to be considering within that. Looking at the protocols within eccentrics and some discussion surrounding when to be utilizing it and why and what this pathology has really evolved over these last few years from that tendinitis discussion to that tendinopathy, and how that Achilles insertion really has that hypovascular zone, and why that eccentrics may be of benefit there. So some great take-home points. Dr. Tahan, lastly, is really driving home the point of plantar heel pain's a extremely common condition. Again, again, great research, great literature, good understanding that there's some things we can do not only with our hands but with our exercise routines as well. But within our healthcare arena, this may not be widely accepted as we're only 24% of these populations are making, or this population are be recommended to our offices. So how do we utilize the literature that we have and really make a voice for ourselves within that diagnosis in that area? So venturing on into kind of more specifics is that Achilles tendinopathy, why it happens in that stress ratio and how we differentiate between that tendinitis, that inflammatory process versus that chronic wear and tear. So we saw in this week's readings on how to treat this. We have some stretching, some strengthening, and regional interdependence. And then we had some great discussion on what population this would be applicable for, especially as we see that Cook et al. Study saying aging doesn't really specifically associate with tendinopathy. So we're seeing patients who are extremely young, to the elderly population venturing into our office, and how do we dose what we're learning here? Because we know that those eccentric protocols, that were first reported by that Kerwin and Stanish in 1984 are really useful intervention for tendinopathy. And it may kind of play on that pathology discussion of, lying down a more vascular infrastructure within that tendon. But if everybody has time before they venture into this next week, take a look at that Karen Silbernagel discussion within JOSPT as she demonstrates, one size doesn't fit all within this population. This is great protocols. We have good evidence, and this is a kind of a foundation for where we should be building off of. But taking a look at that patient in front of you and obviously treating above and below the joint if need be, and looking at that patient as a whole, and then dosing what we're learning appropriately into what their requirements are. So good literature there. And kind of that Roos article again, we're seeing pretty solid evidence that those eccentrics are of benefit to these people. And I tell patients, I don't know if anybody snagged that out of the article, but 33% of patients have muscle soreness from the eccentrics, but really still they're seeing benefit. So maybe of benefit to tell the patient, especially since we know it takes a little while to gain that strength, so you don't want to lose the patient before they get there. The plantar heel pain, again, we're seeing some interesting articles on what it is and what we're exactly looking at, and how do we treat it, and then And then again, how do we market for it? We know that our manual therapy research, that Cleland and Amisha et al. has general understanding that we're doing well here, but how do we get that point across to elsewhere? Um, and looking at that McPoyle article was a good understanding of the infrastructure of how to treat these patients as they kind of ran us through that acetic acid and dexamethasone and manual therapy techniques that are supported and calf and muscle strengthening that we should consider as well. So a really good comprehensive take-home research article. Some housekeeping items. Continue to work on your group projects. Communication is extremely key here. Keep in touch with us TAs. We would love to be of assistance if you guys need anything for these group projects. If you guys have any discussion points that you want, you're welcome to get a hold of us at any time. And then continue to plug away. I know it's a light at the end of the tunnel, but you guys have some great discussion coming up with ankle sprains and so stay present and continue to plug and get your posts in as early as possible so we can get them graded and you guys can continue to discuss early on. So coming up is your guys' ankle sprains, forefoot disorders, and post-op management. And again, you guys 2 weeks left, so don't lose us now. It's a hard time in the class to remain concentrated and focused, but stick with it. It will be of great benefit to your practice. Other than that, you guys have a great Sunday. Enjoy, if you guys are in the Midwest, some beautiful days. Take care. Bye.